Alright, I'm going to be covering amenorrhea and oligomenorrhea, the pathophysiology behind it, and the initial workup. However, I want to say for this, I found that Williams Gynecology, second edition, chapter 16 is my primary source, and it's amazing. It's going to be my primary study guide, and so I recommend everyone go on to Access Medicine, read chapter 16 if you want some background, chapter 14 and 15, and then if you want some advanced information, chapter 18. It's a great resource mainly because of the fact that it lists all of the scientific papers that it's getting information from. So it's not just one of these books where you go to and get a source. It's also going to give you primary information for evidence-based medicine. So this is Jane, and Jane comes into your office and says, I haven't had a period. So we want to classify amenorrhea in two different ways. Some texts say that it's actually bad to do this classification, but in our lecture the other day, this classification was actually used. So there's primary causes and there are secondary causes. So primary causes, and I'll just put secondary. And so primary meaning that it's the cause is going to completely prevent menorrhagia for your entire life. So you never ever had a period, and you never would actually have a period if the condition wasn't corrected. So it's for children that have never had a period. And then there are the secondary causes where you've stopped having a period, stopped having one for more than 3 months. Now, what is the problem with this classification scheme? Well, some of the things that can cause this secondary amenorrhea can actually present in children that have never had their period yet. And so if you just look for these primary causes, you may actually miss the true cause of the amenorrhea. But just being aware of those things should make enough of a difference to be able to go ahead and classify as primary and secondary without having any problems, just being aware that you could have a secondary issue in a primary patient. So one of the first things we're going to ask Jane is, Jane, how old are you? Have you ever had a period? And if she says, I am 14 years old, I am 16 years old, I've never had a period, whatever the case may be, you're going to start by maybe suspecting primary causes, but you're not going to rule out any secondary causes. On the other hand, if she says, hey, I'm 24, I had my period and it stopped about 5 months ago, you're going to have secondary causes high on your differential, very high, but you're also going to realize that in some very rare cases, these primary causes may be present in secondary individuals, but it's extremely rare. In order to understand amenorrhea, we have to understand first what the natural physiology is. So we're going to start at the hypothalamus. We have a hypothalamus, and what the hypothalamus does is secretes a lot of hormones and mostly acts on the pituitary. So in this case, we're going to look at it secreting gonadotropin releasing hormone. So just a little background on this. The ovaries and testes are called gonads, and so gonadotropin releasing hormone is a hormone that causes gonadotropes to be released from the pituitary. Gonadotropes act on the ovary and the testes. It's also important to know that the gonadotropin releasing hormone is secreted in natural pulses, and so then that's going to act on the pituitary. Specifically, it's going to act on the anterior pituitary. So pituitary. So this is the anterior pituitary. I'll put an A and T right here so you remember it's anterior. And whenever it gets acted on by gonadotropin releasing hormone, it's going to release two primary hormones. So the first one it's going to release is follicle stimulating hormone, FSH, and the other one is going to be a luteinizing hormone. Follicle stimulating hormone is going to act to cause follicular development, while luteinizing hormone is going to act on the corpus luteum to maintain it. This all is going to take place inside the ovaries. So what we're going to get is, we'll get some follicular development, and production of steroids. So I got the follicular development and steroids. So what are those steroids? Those steroids are going to be estrogen, progesterone, and also you can get androgens, so androgen production. Then the last thing we get from the ovaries is a peptide hormone called inhibin, and so it's going to create inhibin. Whenever the follicle is pretty much established, inhibin is going to act by giving negative feedback on follicle stimulating hormone. And this is going to prevent multiple follicles from developing. So you're only going to have one follicle develop. So the first one that starts to grow, it's going to produce inhibin, and FSH is going to be inhibited to stop other development. Now the steroids as a group are all going to act on basically two main structures. They're going to feed back and inhibit the hypothalamus, and they're also going to feed back and inhibit the pituitary. So you want to basically stop the FSH and LH. Now estrogen is kind of a rebel because after a while you start producing a ton of estrogen, and when estrogen just basically surges, instead of inhibiting, it switches its role and it starts giving positive feedback on luteinizing hormone, causing luteinizing hormone to increase. And then the luteinizing hormone in turn goes back and enhances the follicle to make sure that estrogen and progesterone are continuing to be produced at adequate amounts after the ovulation. So luteinizing hormone will maintain the follicle for a short time after ovulation. Now this and all, well, looks like a nice fun game to play of figuring out where hormones go and where they act, but what we really want to get down to is the uterus. So here's our ovaries, and here is the uterus. So I have my uterus here. I have my vaginal orifice and my vaginal canal there. And so this is where, so the estrogen is coming over here. Estrogen is acting, and it's causing a thickening of the endometrial layer of the uterus. It's thickening it up, and it's causing veins to grow into it. Well, not veins, but arteries, capillaries, veins, the whole deal is growing into it. The whole blood supply is increasing. So if you have an egg implant in here, it will start producing HCG, and HCG will go back and act on the ovaries and say, all right, ovaries, follicles, it'll maintain the follicle. So essentially it's acting to maintain the follicle so that you keep your estrogen, progesterone, all the steroid levels high. If, on the other hand, an egg doesn't implant in here, then slowly the luteinizing hormone will calm down, and you'll have the decreased estrogen, all the decreased steroids, and that's going to cause the endometrial layer to stop being maintained, and it will start to basically bleed away. And a young girl will wake up and she'll say, menses. Just as an aside, a fun aside, the word menses comes from the Latin word that means month, and the word month comes from another word that means moon. And so this is the female's moon. So now that we know how menses occurs, we can say that you can have amenorrhea by having a negative or irregular physiology or anatomy from top all the way down to bottom. How can we interfere with these things? Now I also have to admit that this was a very simplified view of menses and the hormones behind it. It's a little bit more complex than this, but I wanted to simplify it for the sake of this objective because what I want to look at more is not how menses occurs, but how it is messed up. And what we just looked at has a term. It's called the hypothalamic pituitary gonadal axis. So if you want a better understanding of all of that, I encourage you to go and Google hypopituitary gonadal axis. Before I go into exactly how to work this thing up, I want to talk about my favorite cause of amenorrhea. And so this is called pseudocyesis, and it's been documented 550 cases. and from ages 6 all the way up to 79. And basically what this is if you believe strongly enough that you're pregnant, it will cause your body to have physiological changes that mimic pregnancy. Now, this usually occurs in people that are depressed, and by telling them that they're not pregnant, it's going to cause them to be more depressed. The treatment for this is antidepressants. I'm just going to put anti-dep. I'm going to organize this a little bit different than Williams did. I'm going to give 3 basic categories. So you have physiological causes of amenorrhea, then you have pathological anatomy that causes amenorrhea, and then pathological physiology. So what do I mean by physiological causes? Well, I'm so glad you asked. By that I mean things that are natural, things that are going to naturally be causes of amenorrhea. And so what we have with that is you can be prepubertal, and if you haven't went through puberty yet, prepubertal, you're not going to have a period. You're not going to have a monthly cycle, and so that would be a natural physiological cause. Another thing would be pregnancy, menopause, and then I put on here also nutrition, exercise, and stress. Now, nutrition and exercise especially, these can be classified as pathological, but I'm going to call them physiological. And because it's your body's own natural protection mechanism to keep you from getting pregnant if there aren't enough resources in your environment. If you don't have enough nutrition to feed yourself, you probably don't have enough nutrition to feed your baby. And so this is your body's protection mechanism for times of hardship. And I think for the most part, we can understand how these would prevent a period or prevent menses. But on these, I want to go ahead and show you the mechanism. I'm just going to say up front that anytime I create a PowerPoint and I import it into my iPad, there's always problems with the lettering and spacing. But with that said, I'm going to go ahead and go through this. So with anorexia, it's going to lead to decreases in leptin, and it's also going to cause changes in insulin, glucagon, and catecholamines. Now, when you're not eating, you have increases in neuropeptide Y. So increase in neuropeptide Y will lead to hunger, and will also lead to changes in pulsatile GnRH. Changes in insulin, glucagon, and catecholamines will act right here. So we know if we have changes in our pulsatile GnRH, it will reduce the luteinizing hormone and follicle stimulating hormone, and then that will lead to anovulation and amenorrhea. However, if we go over here and we look at stress, so stress will cause increases in CRH, and then increases in CRH can act to increase opioids, just the same way that exercise can cause to increase opioids or beta endorphins. CRH will also cause increases in cortisol, and cortisol will have an effect on pulsatile gonadotropin releasing hormone. And increased opioids will also act directly on the pulsatile GnRH. And so we see that there's sort of a common mechanism for all of these. And here's the thing, whenever you have anorexia, studies have shown that anorexia increases stress, and it also has been shown that people who have anorexia will tend to over-exercise to maintain their figure or their weight. And so with anorexia, you get a triple combo of all 3 of these things acting in concert to change the pulsatile gonadotropin releasing hormone, and with that you're going to have anovulation and amenorrhea. So up next we have the pathologic anatomy, and instead of going through these, I'm going to kind of walk you through it in a picture. This picture was labeled for free reuse. It was posted on Wikipedia, and so I'm using it without breaking any copyrights. Wanted to point that out really quick. So what really happens is if you have Mullerian agenesis, all of this, except you'll have your gonads, but all of the rest of this will be absent. Without a uterus, you can't have menses. It's just a fact. Sometimes you can also have intrauterine adhesions, and so with the intrauterine adhesion, you're preventing the flow of blood, and so you can have amenorrhea or oligomenorrhea depending on how severe it is. Some different things can cause this. One would be scar tissue, so like if you have damage from, say, an intrauterine device, then you can get scar tissue and have intrauterine adhesions. Certain types of intrauterine adhesions are known as Asherman's syndrome. And so that would be another thing that can cause an intrauterine adhesion. If for some unknown reason the cervix was stenosed, so if you had cervical stenosis, that could also block the flow of blood coming out, and so that would also be a cause of amenorrhea. Also, you should know that the endometrium, so you can see right here the endometrium, it's maintained by a basal layer. So if this basal layer that's maintaining the endometrium, if it gets destroyed all the way around, you are no longer able to grow an endometrium, and so the effects of estrogen and progesterone, all these different things, will have no effect because they have to act on that basal layer of the endometrium in order to cause it to proliferate. And if it's gone, you can't slough off the endometrium and you can't have menses. In some cases, especially with genetic problems, you can have a transvaginal septum, and so basically a septum going across here, transvaginal septum, and that would prevent the flow of blood, which would cause amenorrhea. And then much more distal, you could have an imperforate hymen or labial fusion agglutination, and that would also prevent the flow of blood or slow it down severely. So there's the pathologic anatomy. So we went through Müllerian agenesis, intrauterine adhesia, basal layer destruction, cervical stenosis, transverse vaginal septum, imperforate hymen, and labial fusion agglutination. Now, those are the two short lists. This list is extremely long, and I have truncated it into major categories. So the pathologic physiology. So you can have hypogonadotropic hypogonadism. You can have hypergonadotropic hypogonadism. You can have eugonadotropic amenorrhea. And I just want to point out the root word on this is amen. So amen to that. And then I listed the most common causes of eugonadotropic amenorrhea, which includes polycystic ovarian syndrome, tumor, hyperprolactinemia, and Cushing's. But I know having this list does very little to help, so I'm going to explain the list. So you remember that your hypothalamus will act by releasing gonadotropin-releasing hormone, and your pituitary will act by releasing follicle-stimulating hormone, FSH, and luteinizing hormone, LH. And then finally, the ovaries will act by releasing the steroids, estrogen and progesterone mainly. Now, whenever there's a problem up here and you're not secreting enough of any of these hormones, then by not secreting those, you're not going to get the action on the ovary, and it's going to cause hypogonadism. So up here I have my gonadotropes. So if I have hypogonadotropic hypogonadism, basically the reduction in the hypothalamic pituitary axis is causing the reduction in the gonads. On the other hand, let's say that everything up here is normal. We got it A-OK. However, the ovaries, whenever you have your FSH and LH and they're acting on the ovaries just say, I'm not going to respond to that. And then you don't get any estrogen or progesterone production. So in this case, estrogen and progesterone typically will feed back and inhibit both the hypothalamus and the pituitary. And when there is no inhibition, it won't allow a decrease in these hormones. So the normal decrease that is caused by the steroids does not take place. So you actually get way more gonadotropins than you normally would have. So you have hypergonadotropic hypogonadism because the ovaries just aren't responding. So what this ultimately boils down to is I can have a problem with the ovaries. I can have a problem with I'll just put the hypo/pituitary. Or I can have a problem with none of those. So if it's a problem with the ovaries, then you'll have hypergonadotropic hypogonadism. If it's a problem with the pituitary, you're going to have hypogonadotropic hypogonadism. And whenever it's none of these, it's going to be eugonadotropic amenorrhea, and amen to that. Now again, I gave you the list for eugonadotropic. These lists are extreme, and I just encourage you to look at my study guide and if you want to know some individual things. But they include both genetic and acquired conditions for both of these things. And so the important thing to know, I think, at this point is just to know how to work these things up and then look for specific causes after the fact. So we're going to go through the workup for amenorrhea. I think first and foremost, you want to get a good history and a physical exam. Now, history, you're going to ask about things like sexual activity, birth control. Like birth control is another possible cause of amenorrhea that I didn't even put on here. But in some cases, females will respond to different birth controls and not have a period. I want to point out that guys can also respond to those same birth control pills by not having a period. I know it's crazy, but it's true. You're going to also want to find about exercise, nutrition. You want to calculate their BMI. And like on the physical exam, you're going to have to get down in the ditches, if you know what I mean, because this is a war zone. But then you're going to want to get your primary labs. So your primary labs, beta HCG, is this woman pregnant? Is the man pregnant? I don't think, but follicle stimulating hormone, this is going to help you determine hypogonadotropic versus hypergonadotropic. Estradiol, hypogonadotropic versus hypergonadotropic. Prolactin, you're going to want to look at hyperprolactinemia. And TSH, you're going to want to look at thyroid. So, of course, again, thyroid, hypothyroidism can cause amenorrhea, whereas hyperthyroidism can cause menorrhagia. And so you don't really want to order a whole lot more labs until you know these basic things. And then you'll move on to your secondary labs. Of course, we're assuming right now that you haven't found any anatomical anomalies during your physical exam either. So then you have your secondary labs. That's going to include, first of all, testosterone is going to help you check for polycystic ovarian syndrome as well as an ovarian tumor. DHEase is going to let you look for an adrenal tumor. 17-hydroxy-P is going to let you look for late onset CAH. This 2-hour glucose and the fasting lipid are good for checking for polycystic ovarian syndrome. Autoimmune panel, because you're going to want to look for premature ovarian failure. And then karyotyping, like I said, there's a lot of genetic causes of both hypo and hypergonadotropic hypogonadism. For example, Turner syndrome, Fragile X syndrome. And I haven't even scratched the surface with those two things, but just keep those things in mind. And then you're going to want to go to your radiological stuff. So a sonography, you're looking again for some anatomical stuff, but mostly the sonography is going to help you to rule in or out the polycystic ovarian syndrome. And then this HSG or saline sonography, saline infused sonography, that will help you to look for Mullerian anomalies and intrauterine synechia. And then MRI's big dog, because it can look both at Mullerian anomalies as well as looking at the hypothalamic pituitary axis, looking at both those things and seeing, hey, is the pituitary even there? Is the hypothalamus going all right? Did they get damaged? Or they have a tumor there? Those kind of things. So you can also have anatomical problems with the hypothalamus and pituitary. If all of these things come back negative, then you're going to want to look at specific diseases, maybe do specific genetic testing and those kind of things as well. And if you still don't find anything, there's a small percentage of the population when they have amenorrhea, it's just crazy and nobody knows why. And so look, you're doing all your testing. One thing you're going to want to rule out is, in your karyotype, is this really a dude? I mean, not a dude per se, but does she have an X and a Y chromosome? Because that would really freak me out if I saw that. But it does happen, because if you don't get enough testosterone in development, then you don't develop the secondary male sexual characteristics and stuff. So just keep all these things in mind. Read chapter 16 of Williams Gynecology, and let me know what questions you have.